I'm so excited on the reality pill today to have this most amazing guest, lecturer, speaker, role model. You've all heard the saying, my main man. This is my main man and my main mentor. Going through residency, I spent years under his tutelage and guidance, and he really helped point me in the right direction, and he's the reason I am where I am today. Dr. Stephen Pearlman is a revision rhinoplasty specialist, facial plastic surgeon from New York City. He was the past president of the Academy of Facial Plastics. He is one of the most revered, admired, and respected surgeons in rhinoplasty. If you're a surgeon, you've definitely heard his name, read his articles. If you're a patient, you've definitely come across his results in your search for the perfect revision rhinoplasty surgeon. He really has taught me so much, and today we're going to be discussing the ins and outs and the realities of rhinoplasty, revision rhinoplasty. Why is it so difficult? Why do we have these problems in the world of patients searching for revision after revision after revision? And really, what is the surgeon doing when we're in there? What are grafts and those kind of things that patients don't seem to understand so well? So he's here to clear that up for us. We're going to have a nice basic talk today, mainly for patients. We're going to do one again in the future that's more geared towards surgeons, where we're going to step up the jargon and the surgical language that we have. So today we're keeping it nice and simple, and hopefully you guys can learn a lot from a person I've learned so much from. Dr. Pearlman today has agreed to talk to me about clarifying for patients. You know, doctors know this, but he is one of the leaders in revision rhinoplasty in the entire world, and he's going to help clarify for us what rhinoplasty really is, what the different parts of it are, the grafting, the risks, and things that people are a bit disillusioned about. Since he is a revision specialist, which means you're at the upper echelon or the top of the food chain in revision rhinoplasty, can you even explain to us why do revisions exist?
Okay, well, let's start with the nose is one of the most complex things we can operate on. Rhinoplasty is considered the most difficult and complex operation in cosmetic surgery. There's so many moving parts. There's nasal bones, there's paired upper cartilages, paired tip cartilages, septum, muscles, ligaments. And so whenever you do one simple maneuver, it can have 5 different consequences. So you have to know what each, if you're doing 20 maneuvers, that's hundreds of consequences you can get in a single operation.
And what would you say? So I'll start with the risk of revision. So when I talk to patients, I give them my spiel, and anytime they say I didn't say that, I say you have no idea how redundant of a human being I am, and how I'm not creative. I say the same thing over and over again to people. So I say it's an impossibility. Here's what I tell everybody. So I tell, and let me know if yours is similar. I say we're going to do the surgery. It's going to take so and so many hours. You're going to have a cast on the first week. The first week when we take it off, it's going to look horrible. It should look horrible. Things should get better over time. So at 3 weeks, you're going to look presentable. That means that your nose looks terrible, but you look great. You look like you as a person, and people have trouble telling you did anything. At 3 months, it starts to look good structurally in person and maybe in photos, but on photos, usually looks a little bit fat from the front and not really defined from the sides, but sides look okay. 6 months, you look good in photos and in person, but it keeps improving. At a year, you're about 80% healed. At 3 years, you're 95% healed. At a year and a half, I go back and I look at the nose, and 90% of the time I look at the nose and I say, you know what, we did our job. This is practically the best we can achieve. Maybe not perfect, but it's as good as I can do with your nose. And the other 10% of the time, I would say, you know what, there's something more I want to change. And that's called doing a revision. And,
right.
So how do you guide people through that?
Well, I have a similar way of doing this. Again, you have to manage expectations. Of course, the first thing is you want to make sure people are ready for the operation. They understand the risks. They understand the high percentage, high meaning 5 to 15%, which is more than most operations, of the possibility of revisions. And even then, most revisions are tweaks. People, a year later say, doc, I love my nose, but there's a little bump here, or maybe a little bump here. And that's most revisions. The percentage of people that are really unhappy is very low. Unfortunately, because happy people don't spend hours blogging on the internet about how great their nose looks. Unhappy people do. So you will hear more about the unhappiness and the difficulties with problem noses than you will about happy patients and their happy results. But it does take a lot of time. And I'll tell someone that, which commonly in a month will say, this is too fat, this is too big. If your nose looks perfect at a month, it will be too small at a year. So you got to give it a lot of time. And there's no way to make that happen faster. It's patience.
And let's say, you're talking to a patient and they say, oh, but I don't want to undergo a revision. And it's a primary rhinoplasty. Do you tell them that this is something you have to accept? Or do you say, keep looking, there's a doctor out there who has 0% chance of revision?
Well, it's what you have to do. Again, it's really a psychological evaluation. And I don't operate on anybody planning to need to do a revision, but I understand, try to make it clear to them that this may be necessary in up to 10% of patients. So yeah, even with a revision, it's even more complex. With your revision rhinoplasty, the incidence of patients who still need to come back for a little tweak is higher because we're taking something which has already been destroyed either by poorly done surgery, by poor healing, or just bad luck, because it's not like taking a car where you take a carburetor out, you put a new carburetor in it, it's worked exactly the same every time. You can do the same operation on 10 people, which you shouldn't. You should individualize them. But if you did, like the old days, it will look great on 5. It will look good in 2, okay in 2, and not good at all in 1. So this is the differences in strength of cartilage, position of cartilage, skin thickness, and healing.
So revision is always a risk. It's always a chance that you'll need to do another surgery, and that's just inherent in it. Now, let's go through realities for patients, because I find them often misguided. And the biggest question, or the one that bothers me the most now, is, do you do it open or closed? You, as the foremost expert in closed rhinoplasty who does open, do you ever go to somebody you admire during a lecture and ask them, hey, did you do that closed or open?
No. I will ask, not if they did closed or open, I look and see what maneuvers they did. So some people say, oh, you can never do tip grafts with a closed rhinoplasty. You can never do tip sutures with a closed rhinoplasty. You can never do an extension graft with closed rhinoplasty. All these things that he is talking about. It's not a matter of, it's can you achieve it one way, the other way, and which is better. If I find a primary is a straight nose, there's a little bit of a reduction in the tip, a little reduction of the hump, a little rotation of the tip, I can do that just as well closed as open, if not even better, because you can see instant feedback. But if I feel that I need to do it open, I'll do it open. There's no rhyme or reason. It's like if the nose is very crooked, if it has a very projecting tip, the tip sticks out way too far, I need to bring the tip back closer to the face. Or again, a complex revision, those I'll do open. And I find that now it's around half my patients I'm doing closed, half open. But in terms of an incision here, that doesn't make someone a good or bad surgeon. So if someone says it can't be done open, or shouldn't be done closed, or shouldn't be done open, that's wrong. Just you find a surgeon you like, you find a surgeon who you believe, you like their before and afters, you think this is the person for you, let them do the operation. Send them out, open and close. This incision, if done correctly, will heal to the point where it'll be barely visible, if at all, unless someone's looking up your nose with a magnifying glass.
Yeah, it's like you have someone remodeling your house or doing your entire house. The last question you're going to ask them is, hey, where do you buy your paint from? Let me know what store you buy. Who cares where you buy their paint from? Who cares? Or, open or close. Who cares if they got started at the back of the house or the front of the house? Like, as long as they do a good job. So open or closed is the wrong question to ask.
No, right. Now, it's you look at the results and see if you believe in their philosophy.
Yeah, see their results. Exactly. That's what guides it. And there are people who get more kind of dainty, leading towards kind of fake noses, and they're the ones that get more super structured, or the natural noses. Now, is there any benefit? It's a question of form and function. Is there a benefit to looking natural as far as longevity and predictability of the nose goes, and breathing?
Well, you brought up form and function. When I lecture on rhinoplasty, one of the most popular lectures I give is called Respecting Structure in Rhinoplasty. The nose was invented, created, or evolved, depending on your personal religious preference, by someone much smarter than me and even you. it's a structure that supports an airway. It needs to conduct air. And so if you affect the flow, you can affect breathing. So when you narrow a tip, when you narrow a nose, when you change a structure, you're weakening it. So that's why I take grafts, which is pieces of your own cartilage, put it to either maintain structure, maintain support, so the nose could look smaller yet not collapse. It's by Bernoulli's law. When you make an airway smaller, there's more of a tendency to collapse inward on breathing. So you need to strengthen that wall with grafts to counteract that change in Bernoulli's law. And so the structure, as I say, form and function go together. When someone says, I want to have a natural looking nose, you cannot look up in a rhinoplasty textbook or even in a magazine, what's a natural nose? Mm-hmm. A natural nose is one that fits your face. And what's interesting that I heard this in when I was lecturing in Europe last fall, I can't take credit for this. The nose should be forgettable.
Yeah.
So what does that mean? When you look at a beautiful face, when you meet someone, first you look at their eyes. Oh my God, what beautiful eyes she has or he has. You look at their lips, look at their cheeks, then you look at the nose. If the nose is too big, crooked, overdone, or somehow looks bizarre, it will attract too much attention, take away from the rest of your looks. So you want to make a nose look better. For most Caucasian noses, it's smaller, upturned, smaller bump, but you don't want to make it too overdone. Some people do want to have overdone, and you can make a cutesy little nose, but you can't go too cute or too small because you won't be able to breathe.
Yeah, so I've seen that as well, where I try, and this is what I try to do. I try to make the nose kind of just blend into the face.
Yeah.
And I tell my patients, I say, if you want a particular specific nose, I'm the wrong doctor. I don't do that. I don't make a cookie cutter nose in a good or a bad way. I just don't do it. I try to just work with what I have. I try to make the nose match the rest of the face. And if I don't work with what I have, if I try to create something that shouldn't be there, it's either not going to look good or it's not going to function well. And right. The noses that look unnatural tend to have a lot of shadows falling on them. They tend to have either asymmetric shadows, or they have shadows of an inverted V deformity, of collapse or pinches and things like that. And when you have a lot of those shadows, a nose that is more snarly, more flared, collapsed, pinched, all these things, it also lends to the nose changing more over time because it has poor structure. Exactly. It doesn't function as well, and it doesn't make the face look soft. It gives it a harsher look. So I found that the more natural a surgeon becomes in terms of restoring every structure that should be there, the better the outcome becomes.
Well, you used the key word, it's shadow. And primary rhinoplasty is about it's generally reducing humps and tips in Caucasian noses, raising the bridge, make it appear narrower in Asian and African American noses, a little more tip shape in both, one by making it smaller in big noses, more shape in wide, fat noses. But in revision surgery, it's about shadows. And I do computer imaging on all my primary and all my revision rhinoplasty patients. So, I try to be honest with the computer and honest with the patient. And the tool I use the most for revision surgery is the blend tool, where I'm blending in the shadows of deep creases and deep crevices that do not look good and also may go along with the poor function. I said before, form of function. Noses that don't look good, look pinched, also don't work well. Noses that work well also look good.
Right. And the question now that we have from somebody right now, and which is what I was going to ask as well, is the reality of grafting. So everybody always asks, do you need to use grafts? Do you have to use grafts? Grafts make the nose look fatter, don't they? They have a poor understanding of what grafting is. And I've told people it's like rebuilding a house or remodeling a house. And if you go and you're going to take a pillar down somewhere and you don't put it back, the house is going to fall down. If you're going to remodel this house, you have to strengthen something that you weaken. So you take something from one place, you put it somewhere else. And often you can use the same pillar. Sometimes you can't. You take the cartilage, which is the pillar, and you destructuralize it or damage it by doing a surgery. Later, you can't go use the same one. You have to bring in a new piece of wood to help this house. In a revision, I compare it to like a house that's been damaged in a fire, that half the house is still standing, the rest of the house is not. You're not going to go use those broken pieces of wood to restructure this house. You need to bring in new pieces of wood, and that's cartilage from elsewhere or grafting. Now, How do you explain to patients what, because I'm sure you've heard that same question, right?
Yes.
So how do you tell them what a graft is or why we use it?
You're the master of analogy with the burning house. What grafts, most of the time, it's your own cartilage. It's natural cartilage. So it's a natural structure. It's not a foreign material that's going to be rejected. You can't reject your own cartilage. The first source is taken from your own septum. So we often fix a deviated septum by removing crooked cartilage. So we can get a decent amount of cartilage from a non-operated septum, from someone who doesn't have a septoplasty. Alternative uses are ear cartilage or your own rib cartilage. So again, depends on how much cartilage we need. So if you Google grafts and rhinoplasty, you'll come up with tip grafts. Those can show through thin skin. But most of the grafts we're using are not grafts such as tip grafts, which are giving shape. They're more structural and support grafts. So spreader grafts are put underneath to support the middle of the nose. They do not necessarily widen the nose. When we first started doing them 15 years ago, and we were suturing it end to end, it could widen the nose. But now we've learned how to wedge it underneath and close things over it so it can not only improve airway, open up the airway, but not necessarily widen the nose excessively. We can use it to support the nostrils. We can use it to raise collapsed bridges. We can use it to support tips that are too droopy. We can use it to extend tips that are too high or in an overly shortened nose, or one that may be too close to the face, also in an overly shortened nose.
Yeah, so I put a photo up of some of your work. I'm not sure if my photo is blocking it.
Yeah.
Hopefully not.
I've seen it before, but I remember the patient. Yes.
Okay, so the picture on the left is the before, and that's what is demonstrating an inverted V deformity or an open roof as well. So you have somebody who's been collapsed by prior surgery, and they have these shadows that are coming right along there. So what you did there was you went and put spreader grafts underneath and popped that area back out. And did you put any other types of graft on top of it, meaning a fascia graft? Did you do anything like that?
What I do is, on her, I don't see her after photo.
I'm not sure how to fix that.
But if you look at her tip, she has what we call an oval tip or an olive tip. In a natural, beautiful nose, the tip should be triangular shaped. It should be a general continuity from the tip.
There you go. Nice.
That's tiny. So it should be natural shape, tip down to the nostril. And that oval tip comes from the nose. Instead of being cinched in a triangular shape, it's brought in like this. Also, that loss of continuity here, the crease extends to the end of the nose. And so the tip looks like the nostril, we call the sausage and two potatoes. Sausages, they're stuck on. When we restore with spreader grafts, the inverted V for the middle third of the nose, the middle vault, alar strut grafts for this portion to support the nostril. So you get that nice triangular shape and a nice continuity from the tip down to the nostril. Those are my two workhorses for external shape. And what you said about fascia is that when we operate on noses, especially revision noses, with thin skin, you can get what's called shrink wrapping. So you can see every little contour, like the shrink wrapping of a boat in a boatyard. It shrink wraps around the contours, and cartilage and bone is not like you're at home making that new table or standing in the chair where you can do smoother and smoother sandpaper till it's perfectly smooth. You may have little irregularities that do not come out of bone, so you cushion it with fascia. You take fascia for either behind the ear, in our temple, covering muscles. These are taken from under the skin. There's no visible loss of tissue. And at the end, we cushion over them like a carpet padding. Just before we finish, we're going to lay a nice smooth layer under the skin so it cushions it, so it doesn't shrink wrap around the work that we've done.
Okay, yeah. So there's plenty of different types of grafting. And in order to restructure a nose, you're just trying to bring in little tools to help do it. Anytime you touch a nose, and it could be any surgery, it is a free-floating structure. So we are not able to recreate what God has made. It's a structure that naturally has a lot of different connections to it. And the second we touch it, we're destabilizing it. There's not one nose that doesn't happen to. So you do destabilize it. So when we go in there, we have to make sure that our destabilization stays strong, meaning it stays kind of how we wanted it to. So grafting is a necessity in many cases. Some people go do what we call a reductive rhinoplasty, which is sometimes just shaving a bone. You don't need grafting for that. Sometimes you go do a little bit of a trim on something. You don't need grafting for that. The classic types of rhinoplasty were mainly all reductive. That means we're just kind of removing things from the nose. And you saw how those all ended up. The extreme being Michael Jackson. So the next question going to the people don't understand is, what is a deviated septum? Because from my understanding, everybody has a deviated septum.
Well, the septum is the wall in the middle of the nose. And so we have breathing goes through both sides. We have called laminar flow. Air goes in the nostrils and down the back of the throat. If you have an angulation in that middle, it'll create turbulence of the airflow, could block breathing on one side. Even the other side, there has to go around the corner and create turbulent flow. So turbulent flow can obstruct breathing. It can contribute to sinus problems, make it more difficult when you have a cold, you have allergies, even cause sinusitis. So internally, when the middle of the nose where we breathe is crooked, that's a deviated septum. The photo you put up, this is a crooked nose, primary. It never been operated before. And not only is the internal part of the septum crooked, which tilts actually opposite where the nose goes, it tilts to his left. The external or top of the septum is going the other way. So his septum is tilting to his left and the top of it goes to his right. So what we need to do is we need to straighten not only the center out, but the top part of it. So this is a much more complex operation. The simple deviated septum operation is done from the inside of the nose. We move or remove crooked cartilage. We move or remove crooked bone. We leave the outer support for breathing, and in most cases, that's it. There's no external operation needed. In a nose such as this, where the nose is extremely twisted, we have to use basically every trick in the book to get this nose not only straighter and looking better, but improve his breathing.
And so some patients I've spoken with have had rhinoplasty and have not had the septum touched, and some have just for grafting purposes, not for straightening or for breathing. So do all surgeons who do noses fix the septum? And should surgeons who do noses fix the septum?
Well, I think if you're going to do rhinoplasty, you have to understand the nose inside and out. And I can't tell you how many patients I've seen for revision rhinoplasty who come in and say, I can't breathe through my nose. And they've had a rhinoplasty and look in and they've got this crooked septum. And they go, how could your surgeon not have touched this? Did he even look at your nose? No. Well, how could you do a rhinoplasty without looking inside the nose? And again, we mentioned Bernoulli's law. So if you narrow the airway just by a millimeter, that septum, which is moderately crooked, may not have an issue before, but now it's come closer to that wall, you can create a problem. You need to fix that before it becomes an issue. If someone does not look in your nose before doing rhinoplasty, you should run the other way. You need to treat the nose inside and out. You need to examine the nose inside and out. Otherwise, you'll not do a complete operation on the same operation that they should have all at once, not just delaying it and waiting until they have problems later on.
So I've heard you say before, as goes the septum, so goes the nose.
Yes.
What does that mean?
Well, the septum determines the shape of the nose. The bones of the upper third, sometimes the bones are a little bit crooked, but 2/3 of the nose is cartilage. And so the septum is the structure that creates the shape of the nose. It may be, theoretically, one of the thoughts of the origin of deviated septum may be either trauma growing up, or maybe when you're growing up, you have a high palate, may cause crowding of the nose, pushes the palate is the roof of the nose. It may cause a pushing of that septum, cause it to buckle, which can push the nose over. So patients who may have a very twisted nose said, well, I never had trauma. How did this come about? It may be a growth factor. So the septum determines the shape and the function of the nose, the angulation of the nose, and you need to master the septum. You need to master the structure to master the nose, especially with a crooked rhinoplasty.
Especially with crooked, yeah. I tell people who ask me, do you have to go after the septum? And I try to explain to them the septum is mainly what the tip is hanging on. That's why the tip is crooked, is because your septum is crooked.
Exactly.
And you can't straighten a crooked nose without straightening the septum first.
Right. If the tip is bigger on one side than the other, the cartilages are generally the same size. Or also you're a vision operation for someone who, I said most surgeons are reasonably intelligent, and they'll leave the same amount of cartilage on both sides on the tip.
Reasonably.
Yet, why is one side so much bigger than the other? It's the structure underneath. That septum is pushing the tip over to that side, making that side bigger, while the other side tends to collapse in towards that void where the septum is curved away from.
All right.
It's the main structure, again, structure and function.
Yeah, so I put a photo of an open rhinoplasty just to give an example to people of what it means to go open. It's just an incision that goes across the nose. Now, is it when people see the incision there, okay, which does not happen on my patients, does not happen on your patients, when they see it there, is it because a cut was made there, or is it because it wasn't cut properly or sewn properly or grafted properly? Does the incision mean that you're going to have a scar there?
Not necessarily. I mean, we all have sometimes scars don't heal well, but if it's incised properly, perpendicular to the skin, and it's closed meticulously, usually cannot see that scar. There may be a tiny little edge that we can go back and shave down a year with a little microdermabrasion under topical anesthesia. Topical anesthesia is a little shave. Looks like you have a little rough spot for a couple days, but that incision should not be visible unless someone's literally closer than this and using a magnifying glass.
Mm-hmm. And so in my young age, can you explain to me what is the history of breaking bones? Why are patients so scared of it when they contact me? It's like asking for closed or open rhinoplasty. They ask like, but do you have to break the bones? Do you break the bones? What's the fear from?
Well, that comes back from when I trained as a resident, and right until my first 15, 20 years in practice, we did them under sedation, not deep sedation. The patients were just a little bit comfortable, and you'd feel the shots, which are not fun, but after 5 minutes, the nose is numb, and you don't care, just lay back and feel stoned on your Valium and your Demerol. But then when you're breaking the bones, you hear this tap, 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 snap. And that can be kind of disconcerting when that's happening to you. You don't feel it, but it can be a little disconcerting. So that has handed down generation that, oh my God, they're gonna have to break your nose. It also has this we're using much finer instruments now, much more delicate instruments. We're making much finer cuts and to manipulate noses much more delicately. But why do you have to break a nose?
Yeah.
The nose is a pyramid. So you've got a pyramid. You shave down the top of the pyramid. You now have a gap called an open roof. And if you don't close that gap, you're going to have a flat top on the nose. So that's what we'll do, that gentle breaking the nose here and here. We close those bones in. That creates a smaller pyramid at that height where we shaved off that hump. That's why it's necessary. People who negotiate with people, oh, I don't have to break the nose. I'll do microosteotomies. That's a euphemism for breaking the nose.
Same
or
shit.
if they don't break it, it may not look good. If it's only a small amount of hump, yes, we can do that. But if you do need to break it, that is 5 minutes in a 2.5 hour operation. It's not a big deal. It means you'll have black and blue eyes for 8 days instead of 6 days. That's the difference. And what you're showing me in the photograph, those dots are using something called a piezo, which I love using lately for open rhinoplasty. It's an ultrasonic bone shaver. This ultrasonic bone shaver actually can cut the bone in a much less traumatic way. We can mobilize the bones and very often have faster healing. It's still very similar to what we're doing with the old-fashioned hammer and chisel, but it's a little more modern, a little more finesse. Is it better? I like it better. It's more fun. But it doesn't necessarily make that much better of a result in the hands of a good rhinoplasty surgeon.
Right, but now you can tell a patient who doesn't want their nose broken, say, well, I'm not going to break it. I'm going
to use my ultrasonic piezo rhinoplasty, which is the latest and greatest. I was one of the first people to have it in this country. I love it. It actually adds a little bit of time to the operation, but not enough to make a difference. Maybe 10, 15 minutes.
Yeah. And do you ever use alloplastic implants, meaning silicone, Gore-Tex, that kind of stuff?
I never use silicone. Sometimes in ethnic rhinoplasty, such as African-American rhinoplasty or Asian rhinoplasty, the goal is generally to create better tip shape. So in thin-skinned patients, such as Caucasian patients, you have thin skin, strong cartilage. You get a smaller tip by carving out some of the cartilage and then rebrushing with sutures. With African American and Asian noses, the skin is thicker, yet the cartilage is weaker. So you actually, even sutures alone is enough. You need grafts of cartilage to support that tip. So a graft to support the tip up, called a shield, called a strut or extension graft, and then to push into the thick skin, a graft called a shield graft to create that tip shape. Unfortunately, in these patients, the septums are usually very tiny because they have tiny noses. So we want to raise the bridge to improve some of that depth. We don't have any more septal cartilage available. So we have options. We can use diced cartilage from their ear, use cartilage from their rib, or we use an alloplast. The only alloplast I'll use is Gore-Tex. The incidence of complications in Gore-Tex is 2%. 1% will have potential for infection. 1%, this sort of tight feeling. That's 1 in 50, which is a pretty low number based on, the percentage of revisions. So we can do the tip with their own cartilage from their septum, raise up their bridge with the Gore-Tex, which Gore-Tex tends to get a mild amount of tissue ingrowth, so it doesn't move around. Silicone is not used. Silicone is still used in Asia very commonly. The problem is silicone may look great and work great and be an easy operation for 2, 5, 10, 15 years, but you get a little bump on the nose, it can cause it to shift around, which there's no ingrowth, there's no adhesion of the silicone. It can then break through the tissue and erode into your nose or literally through your skin. So this is one of the problems using alloplasts, which is foreign materials.
So now I got like one last topic to talk about, and then we have a lot of questions that people want to ask you. I want to go over non-surgical rhinoplasty. So non-surgical meaning with fillers. Is this something that, I hear a lot of people, doctors talk about risk with blindness and with all these other things, but then I see them injecting the areas around the nose, which I feel are equally as risky for blindness. And or is it something that you think is safe in the right hands, never safe? How would you describe to doctors? So you're a revision rhinoplasty specialist. Like you deal with the horrendous noses. You understand the blood supply to the nose, and you understand fillers because you do fillers. So can you guide us through your risk-benefit explanation?
Okay. Well, the first thing is that for non-surgical rhinoplasty, it is mostly using fillers. You want to stay in the midline. The vessels to the nose tend to come from the side. So blindness comes from getting filler into a blood vessel that goes backwards, retrograde, and then into the eye. And the most common area is when it's injected in this area of the face. It's extremely rare in rhinoplasty, but has happened with injection or non-surgical rhinoplasty. So you want to put the filler right on top of the bone because the vessels are not at that level. Literally, we tap the bone right on top of the cartilage, even here in the tip, right on top of the cartilage. That's safe. When you go off the midline, up here you have the blood vessels, and in the skin area, you can have, in the lower 2/3 of the nose, if you run your finger, you feel it's tight. There's not here's a lot of mobility. Here it's very tight. So if you put filler in, it can compress the blood vessels, compress the blood supply to the skin, and you get something called necrosis. Not necessarily blindness, but necrosis is blocking the blood supply, and you get literally rotting of the skin. So for creases, for nostrils, I never put filler in these areas. I stay in the midline. In the right hands, in skilled hands, non-surgical rhinoplasty is certainly a good procedure. It's also limited in what you can achieve because you cannot make the nose smaller with non-surgical rhinoplasty. You're adding. So if you have a bump, and this is deep, called the radix, and you fill this a little bit, the bump looks less prominent. So that can look great. I've seen some beautiful results. Filling a little bit above bump, a little bit below the bump, even adding to the tip a little bit. But if you have a big bump and the nose starts from the forehead, you're not going to be able to make that look smaller or look more attractive by adding to it. You're just going to make the nose look ridiculous. So you have to select the right patients, the right indications, and someone who understands the anatomy.
Yeah. Yeah, I say the same thing. If you're going to do revision rhinoplasty, just know the limitations of it.
Yeah.
You can't go change your nose around with it. You can't fix big things in symmetry. You can't augment the nose too much to grow too much. There's a lot of issues other than the immediate risk that you have to worry about with
Yeah.
maintaining filler in the skin for a long period of time, and the nose can cause expansion effect of the tip. It can cause it to look fatter as it brings in more water, or if somebody puts the wrong filler, what are you going to do? So
Yeah.
as long as it's done by somebody really, really good, I think you're fine. So we got a lot of questions. There were actually a couple on cadaveric rib.
Okay.
So people want to know, what are your thoughts on cadaveric rib, and if well, this is like 5 different questions. Here's just one of them. So,
Yeah.
what are your
Sure.
thoughts on cadaveric rib versus autologous rib in terms of different parts of the nose, and then cost?
Right. Well, cadaveric rib or a donor rib is taken from someone's donated their body, is treated with chemicals or radiation, so it cannot carry disease. It also is the shell of the cartilage, so it cannot be rejected like a kidney transplant or a liver transplant. So what happens is we use this instead of using, when you find the septum is enough, instead of using your own rib, we use cadaveric rib. The problem with donor rib is that anywhere from 5% to maybe almost 10% in some patients may dissolve. I take patients about up to 5%. So you do this big operation, it may dissolve over a number of years. Sometimes I'll use a cadaveric rib in either an older patient who may have more of a brittle cartilage, or they want to have a much simpler operation. But a young person, 20s and 30s, you want this to last for another 70 years. And so I think there's nothing like using your own cartilage and using cadaveric rib. I will use it, but my first choice is using the patient's own ribs. I don't think there's anything wrong with it, and I will use it for structure in spreader grafts. I use it for alar strut grafts, for an extension graft. I don't like it for dorsal onlay. Then again, I had a patient a bunch of years ago. I used it for dorsal onlay, and it still looks great. He's actually someone who had something called medporn in his nose that was infected. The surgeon carried it for 6 months, kept treating him. Infected foreign implant, you have to remove it. And I wasn't going to go and put his own rib into this recently infected nose, but he said, listen, I'm a hairdresser. There's no way I'm walking around with a scoop nose for 6 months till this goes away. I want something right away. He was afraid he was using his own ribs. So one of the first patients I ever used cadaveric rib in was this guy. He's now 7 or 8 years out and looks great. So I'm not saying it doesn't work, but I still tend to err on the side of using your own rib if allowable and if the patient will allow me. I mean, taking your own rib is not as big a deal as it seems.
So do you have an age cutoff? I have usually patients over 50, just depending on how their body looks to me. And if I think they're going to be extremely calcified and I need a lot of cartilage, I will just order the cadaveric rib to have it there as backup. Do you have any kind of age cutoff, or do you poke needles in there like some people do?
Well, I always have it in the office. I have it available, and I have it. It's in the freezer. You can poke through the skin, but you can't always get that accurate a result. I do know some of my friends who do a lot of ribs will say they don't care what the age of the patient is. Older tend to be more calcified, although one of the advantages of calcified cartilage is it tends to warp less.
Right.
So again, my preference is generally the patient's own rib. Although if it's someone that I think I don't need much, I can usually get away with ear cartilage, which is not good for structure and strength. It's good just as a filler for spreaders, for onlays, a little bit of tip support, but not major revision. If I think that I have enough with ear cartilage, maybe I think the septum is decent, but not sure because it's a revision, I may say, you know what, I may need one little piece of cadaveric rib. So I have it as a fallback, not necessarily as an initial plan.
Yeah. Yeah, and I like ear cartilage too for small bits of cushioning, support, that kind of stuff. I feel that patients who have had too much ear cartilage kind of put in there, I'm always worried. Well, from the revisions I've seen, that if people restructure an entire nose, those are the ones I've seen that are extremely scarred. It's just they didn't support anything properly. But I love ear for little tiny bits of cushion here and there. But otherwise, ribs kind of the go-to.
Ear's mushy. It's mushy and soft. So you want to take a strong nose and project it out or lengthen it, and you have this contraction. This ear cartilage is going to lose.
Hmm. Yeah. So I agree. Another interesting question is how many revisions or rhinoplasty can one patient go through before the nose collapses? I mean, one can do it.
Yeah, it's not a function of how many surgeries you've had. It's a function of what's being done. So as we talked about extensively, is that the basic principle of most rhinoplasty is restoring and adding structure. And people would talk about Michael Jackson, but he wanted to have a smaller nose. Each operation was smaller and smaller and smaller and smaller. It kept removing. Nothing was ever added back. So the only thing that can get risky is the skin. And the skin can become condemned after too many operations. But we even have things we can do for that now. We can do something called nanofat. We take fascia and inject nanofat, which has stem cell properties, and that will help not only support and nurture skin, but I've even seen skin that looks really beat up look significantly better after using this nanofat.
Yeah, and I like to explain to patients too that when we're doing these surgeries, I'd say during parts of the surgery, our hands are tied behind our backs because we're dealing with a fixed a fixed phenomenon or a constant and a variable. The variable is that we can move the infrastructure around that we're molding, but the superstructure, which is the skin and the muscle and the fat, doesn't change in general. Right. So we can't control that. All we can control is underneath. So back to analogies, I always tell people it's like you have a tent and the tent's made up of sticks, and you can have either a thin sheet over the tent or a thick blanket. Whatever that is, you can't change it. You just have to deal with it. And if you go try to weaken these sticks under a thick blanket too much, like a big fat duvet, it's just going to collapse right on top of it and become a fat looking nose.
Yeah.
So
Honey, I'm gonna go pluck the chicken.
Wait, come on.
So let's talk about that then. Okay, so we answered those. Another question is, why do rhinoplasties change over time?
It's just healing, and you get contracture of the skin, as we talked about. The cartilage weakens, and as it heals, it's contracting down. It's just a function of how people heal and how you have this bag of multiple cartilages, bones, and skin that is reacting to trauma, and the body reacts by squeezing down and scarring. And then you can see it after someone's had a burn, it scars down. You're just getting this contraction. No one really knows why it happens longer in noses, but that's just the nature of the beast.
Yeah. And I've heard this from many patients as they come into me and they state the fact that they have learned and they're teaching me that I know that the nose grows as you get older. And I say, wow, I'm like, where'd you learn this from? How do you, which book was this in? And so I try to explain to them my understanding. What's your understanding of the nose changing over time?
So what happened, the nose doesn't grow as we get older. What happens is, and it doesn't even droop, but I used to think that the nose droops because the ligaments that hold the cartilage to the bone lengthen, the skin sags, and the tip falls away from this bony hump, makes the hump look bigger. Now, I've actually may be wrong. Val Lambros, who practices down in Newport, has studied facial aging and using 3D imaging, looking at patients 15 years apart, has changed the way a lot of us look at facial aging. So what happens is, we talk about the nose pulls down when you smile. You smile, the tip pulls down. And actually, the tip doesn't move. This goes up, but the tip is in the same place. Same thing with the nose growing. It isn't growing. It looks longer because we lose bone in the mid-face. So as we lose bone in the mid-face, the base of the nose goes back and up. It rotates upward. So if this is up, the tip looks like it's drooping. The angle is more acute than where it was 15 years ago. But in reality, the tip is exactly where it was before. So when we can restore that by resuspending the tip or supporting the tip in aging noses. But again, as we age, it will age from there. Another question which you didn't ask, but I saw posted there, is that when we do rhinoplasty, the nose will actually age from where it is. Not like all of a sudden in 15 years, some alarm will go off, it's going to drop to where it would have been. It ages from where it started. Just like with a facelift. We turn the face back 15 years and ages from that point.
Now, I've seen, interestingly, I don't know if you've witnessed this too, I've seen the nose look better after a facelift. And I have trouble understanding what it is that improves the shadowing around the nose. I am assuming it's because there is less exaggeration of the alar crease as it comes around following the nasolabial fold down, because that shadow has been alleviated and the weight's been kind of taken off the nasal sidewall as well. So have you heard of that? I've heard of that a lot. I just don't, I can't figure out what it's actually caused by.
That's news to me. But what is true, they've shown that people who get rhinoplasty, aging, older patients getting rhinoplasty also look younger, because we've had that nose, which either droops or appears to droop, but bringing it up makes them look younger. And they've done studies showing that people looking at matched patients before and after always judge them younger following rhinoplasty.
Yeah. And I've seen a lot of patients for lip lifts who come in saying, I had a rhinoplasty, my lip got longer. And I've seen this repeatedly, and I've looked at the structure of the nose to try to figure this out. And they said that they went to their surgeon, and they said, it's impossible, it's impossible. And you look at the nose and it's deprojected and all this stuff. So what are your thoughts on the possibility of that?
Well, first, foremost is we're raising the tip in most of these patients. So raising the tip, you see more of the lip.
Mm-hmm. But not in your hands. I'm talking about a surgeon who doesn't support the nose. Is it possible?
Well, even then, they still get tip rotation. And you don't have to necessarily support the nose to get tip rotation or tip over rotation. Look at the nose that were done back in the 60s, the 70s, all those overly rotated noses. They weren't supported yet. By cutting out enough structure, the nose can significantly rotate upward. So a rotated tip, you're making this appear longer. The second possibility is when you go down there and you work at the base of the nose, you're releasing the depressed septum muscle, and you may get some loss of support of the lip. Now, the depressed septum muscle is a muscle that begins in this area of the nose called the columella, and it can insert either into the columella, into the spine, into the skin of the lip, or into the lip, or some combination. So depending on where it inserts, when that muscle is cut, also may cause some relaxation and lengthening of the upper lip.
Okay, yeah. So I've seen that. I've seen also the way I like to think of the natural positioning of the posterior part of the medial crura is kind of sitting over the septum. And a lot of the time now what I'm doing is I'm doing like a posterior tongue and groove, where just on that posterior portion, I just secure it back, whereas the rest of it's still free for a strut or whatever you want. I've seen a lot of people just put in a columellar strut, bind it tight together, and it bows their columella slightly. And in those patients, I've seen that their smile can't go up as high anymore because they're getting kind of stuck in front of the septum instead of the medial crus wrapping around like the nasal spine.
I think you know technical for our audience.
Yeah, we've got doctors that are.
Yeah.
That are
good. That's the kind of conversation I would see when we're both sitting on the same panel at some national meeting. I mean, you're sitting down the other end of the table, and they show a nose, and you're discussing your technique. I'm discussing my technique, and we argue about who's right and wrong.
Yeah. But there's doctors that are watching. They're watching for you, not for me. like Pearlman's here. Let's go learn something. So how do I find or choose the best plastic surgeon for my revision? I mean, that's easy. You go to New York. Dr. Pearlman is right there. You just open a new office.
Well, you want to, first of all, is this the majority of their practice? This is not just someone who does it. Do they lecture on it? Do they publish on it? Are they respected by their peers? What are their credentials? And look at the before and afters.
Yeah, and not just one before and after that you like, saying, multiple, I love what they did with that one nose. No.
Look at the gamut. And not everybody's on our website. We have dozens more in a book in the office and iPad, because not everybody's going to give permission to use their photos on the website, because we do respect privacy and HIPAA. So the website are selected patients who have given us permission, but hopefully, and we've done enough that we've got enough patients we can share on our websites. But in the office, we have many, many more you can look at. And so it's not just, am I a good showman? Do I have a beautiful website? Do I have great marketing? And do I do nice imaging, graphic imaging? So you can be a great graphic artist and make a good surgeon, but look at the before and after and say, you know what? His results speak to me. This is the kind of results I want to see. Or, you know what? This isn't my taste in noses. Maybe I should go find somebody else.
Yeah, and the biggest mistake I've seen are people who assume they saw one photo of somebody who looked like them and an after that they liked, but they ignored all the rest of the photos.
Yeah.
The chance of you getting the same results when you haven't, liked all the other photos is very, very low. You have to see reproducible results and photos that you like, meaning you look at the surgeon and the results and like what they do, maybe not every time, but 90% of the time, something very high. You have to like all their results because you don't know what the capability is going to be of that surgeon in the situation of your nose, and you don't know what they're going to go do regardless of what they told you. They can go make a graphic design that looks perfect, or they can tell you, that they're going to do this to your nose and that to your nose. But their ability is solely, I'd say, dictated by their prior photos. That's the only way you can predict what a surgeon's going to do, regardless of what comes out of their mouth or what they show you in a picture.
Yeah.
Yeah. So past that, I'd say we're reaching the end of our hour. I can keep talking to you. We should do one, I'd say, more geared towards doctors, where we can get more technical and people won't be upset when we talk about like tongue and grooves and inverted V's, all these kind of things. So I think it'd be great. But if you guys want to find Dr. Pearlman, this Instagram live video will be placed back on the Reality Pill podcast page, and the actual podcast video is going to be placed on YouTube pretty soon. If you want to visit Dr. Pearlman, he's in New York. It's well worth the flight to do a revision rhinoplasty, that's for sure.
And my website is mdface.com. Easy to remember.
Very easy. So it's mdface.com, info@mdface.com. And hopefully we get to talk again to do a doctor-geared segment, because we have no meetings coming up. Yeah, it'll be awesome.